If you look at the top of the stomach, it's a key part of your body that controls when your brain says, let's stop eating. Because as that expands, there are these receptors, mechanoreceptors at the top of the stomach. As it expands with food, those trigger nerve signals to go to your brain and tell you, okay, we're satisfied, I'm gonna stop eating now. By ablating that area, it tightens down, it shrinks down, and that set point, those mechanoreceptors register earlier. And so you eat and you say, I am finished with much less.
Dr. Chris McGowan, welcome back to the American Glutton podcast.
Thank you for having me back. Great to be here.
Dude, so since the last time we talked, I feel like GLP-1s have exploded, which is a big deal. But then there's something else I really was interested in talking to you about, which was this study, I think out of Harvard, and it's terrible that I can't cite the name of the study because, and honestly, I don't even know how to read these things exactly, or I'm not a science person. But what I gleaned from this was that they have seen evidence that fat cells retain a memory of being overweight. There's an epigenetic shift. So basically, they're saying scientifically we know if you gain weight and lose weight, your body will want to regain the weight. The fat cells will want to go back to being overfilled. And so suddenly it's like, okay, we have all these tools on how to lose weight. We know, I can do diet and exercise. I can come see you. I can take a GLP-1. There's all this different stuff. But no matter what, our body will basically be fighting us forever.
Yeah, I think there's a lot of truth to that. I'm not certain of the exact study you're referring to, but really this is getting to that set point theory that we've all heard about. It's getting to all of the mechanisms that are in our bodies specifically to preserve weight. That's what they do. And it relates to survival ultimately. And that's why it's so much more than willpower. When you're trying to lose weight and maintain weight, because your body is desperately trying to get back to where it was. And you're right, there's all these tools that can help you lose weight, but what are we going to do for the long term? How are we going to keep that weight off? That is a much bigger challenge.
That's kind of that's been the whole game. For many years, I spun my wheels with just this idea of I need to lose weight. And it finally dawned on me, that's not the game, because I can bury my head in the sand for a month or two and grind out when white knuckle the discomfort of losing weight. It's really just kind of becoming a little bit of a masochist, or going I can take the suffering, but I can take the suffering on the short term. I can take the suffering when I see a finish line. I expected that once I got through the finish line, I would be done. There's no more suffering, right? Because I've lost the weight, and that's the hard part. Well, it turns out, no, it's kind of it's a long-term thing. And then all the systems in my body, the hormones, are all conspiring, all the baggage and nonsense that got me to where I was in the first place, which is compulsions and discomforts. And when I'm saying discomforts, I'm talking about mental discomforts. Because to be honest with you, I didn't really overeat due to hunger. It wasn't I'm sure my hunger's probably revved up more than a very lean person's hunger. Fine. But I wasn't walking around all the time going, gosh, my stomach feels so, you know what I mean? It was more just that if I eat that thing, I'll feel calmer. I'll feel more relaxed. It will fill this emptiness within my soul almost.
Yeah.
But then
everyone's different.
Everyone
has
different.
Different factors leading to excess weight. For many, it is hunger. And
yeah, sure.
You've talked about that many times, the food noise, that's legit for many people.
Yeah.
But it has to do with all of these hormonal pathways that are indeed conspiring against your efforts. They are there for a reason. They're not very intelligent and not able to understand that you may have other motivators in losing weight. So they're there as protection. But when they're out of balance for an individual, then, well, it disrupts or alters that energy balance and appetite balance. And that's why someone is more prone to gain weight. That's definitely a fact. And we're constantly battling against those.
And so that's what I really wanted to talk to you about. In your practice, what are you guys doing about that? Because you guys have great tools for weight loss. What's the next step? You know what I mean? Like, what is the forever plan?
Well, let's take a step back and look at, you right out of the gate, you said, look, GLPs they dominate this field, right?
Yeah.
And I'd say 2022 into 23 that was really the year or years of the GLPs, and 2024 was probably the year of compounded GLPs. If we're going to really look back, talk about a disruption. You look at the brand name Wegovy's and Zepbound's that disrupted this whole field in a very positive way, of course. But then last year, there was this emergence of everywhere, seemingly everywhere, you could get your hands on these compounded versions and still can. And so millions of people are on these medications. What we're seeing, though, is
can I just ask you? I'm sorry,
please.
Just because what is the difference between when you say GLPs and suddenly there's like Wegovy and compound? What does that mean?
Yeah, let's talk about that a little bit. So the brand name medications for weight loss are Wegovy and Zepbound. Their sister medications for diabetes are Ozempic and Mounjaro. Okay, those are the FDA approved prescribed medications that have been in shortage since they were introduced because there is such demand. There is essentially a legal loophole that allows for compounding pharmacies to supply medications when there is a supply shortage. They can fill the gap. Mm-hmm. These are not directly FDA regulated, tested, approved. They're provided by compounding pharmacies, which is a very different field than your Walgreens or CVS. Okay, and there's really no regulation whatsoever of those medications. That is what has flooded the market. So when you Google, if you say, I want to use Ozempic, what's going to come up? All of these cheap sources of medication that aren't actually the same thing. They are compounded versions of semaglutide and tirzepatide, which won't be available any longer, but because it's back in supply, the brand name one is. But the fact is, if you see $100 a month for semaglutide, that is a compounded version. And all of these companies are now providing these. Okay. It is a massive cash grab right now. And not to get too controversial or provocative, but that's what it is, because this timeline will expire for the compounded meds. Once Novo Nordisk is able to fully supply Wegovy, the FDA will cut off that little loophole that allows these to be around. But for right now, they've saturated the market. You can get them from wellness spas, from Weight Watchers and Row, and all these companies are providing them.
Okay, I see. I get it. And so when they have multiple factories churning out the brand name, then the other companies won't be able to sell them, I guess?
Yeah, exactly. So recently, tirzepatide or Zepbound was no longer in shortage. The FDA kind of removed that label, so that's not able to be provided in a compounded fashion. And the next would be the Wegovy and Zepbound once that occurs. And Ozempic once that occurs. Timeline's not defined yet, but we know that's inevitable. So all of these patients who are using these medications, and some may be doing tremendously well. I mean, that's great, but there is an expiration to this pathway.
Right.
So we know all of those people will have to come off of those versions. But we also know that many people using the brand name meds also come off of them. In fact, most do. About 2/3 of people will stop the medication within a year. What happens at that point? That's the problem that we're now encountering, which is not just that you regain weight, but that hunger comes back. So if you're someone who had that food noise, it comes back even stronger. What do we do at that point?
Right, because this is the way I always have looked at this is it's just making dieting more comfortable. Like your body is going through whatever it's going through. If you're losing weight fast, then you're crash dieting. Like the whole thing with, I remember Ozempic face was a big thing. Like people, that just meant people were losing weight really, really quickly, losing a bunch of lean tissue, which happens on any extreme diet, will produce lean tissue loss. But I mean, it doesn't change your physiology. If you stop taking the medication,
No.
you're gonna be back to square one of like with any diet.
Yeah, there's no permanent change. And I should establish that I am a proponent of any treatment that works for weight. I prescribe GLP medications to many, many, many patients and have from the start. But I also am very realistic with my patients and really establish that ground rule, which is you have to stay on them. You have
Yeah.
to, because once you stop it, things go back to the way they were. Some of these medications are as effective as a weight loss surgery in many instances. But what if you had a gastric bypass and reversed it? Because that is essentially what is happening if you're on a medication doing really well and stop it. You're reversing the tool, the intervention.
Right.
And it's important to understand that. I think maybe a better analogy, people talk about this is like treating blood pressure, right? You're on a blood pressure medicine, you stop it, what's going to happen? Your blood pressure is going to go up. You don't want to stop it. Like everyone can understand that. I think from a physical standpoint, I would use the analogy of a bodybuilder using anabolic steroids. So what's going to happen if you and I inject testosterone into our bodies? We're going to make serious gains, right? We're going to lift heavier. We're going to put muscle on. We're going to put a lot of mass on. And you might say, all right, now I'm at a really good place. I'm lifting more weight. I want to maintain this. I don't need that anymore. I'm going to stop it. Well, what's going to happen? You're quickly going to shrivel back to where you were. Now, it's the reverse process, but the analogy is the same. The mechanism's the same. We're providing super therapeutic doses of a hormone within the body. And when you cut it off, things just go back to how they were.
Yeah. My fear, you know, and this is my fear partially because my own experience is like, look, if these had come out 10 years ago, I would be on them for sure. And I'm sure I would be on them and with the expectation that I'd get off once I lost weight. You know, I'm sure of that. But the majority of the other people in my life that I see dieting on a very regular basis are not people that need to lose hundreds of pounds at all, like I needed to lose. They're people who need to lose a few pounds and are just as obsessively dieting as I was to lose my, you know, in the last 10 years, it was really down to like 150 pounds at the most is what I needed. You know, I'd gotten off a bunch. And if they're going to jump on instead of doing, you know, like I hate to, you know, I use her as an example all the time. My wife has had these 5, and sometimes she'd go, no, it's really 5 plus 2 pounds that I want to lose. If someone like her and her friends were going to jump on these medications in the way that they would do the crash diets, despite me going like, please don't do that. Diet's crazy. That, you know, 600 calorie a day diet. That's why you keep battling these pounds. Like, I think like, if you just ask me, you're so beautiful and like, you don't need to lose weight. You're very healthy, but to battle those very few pounds over the long haul, my fear is like people jumping on and off of these medications, quickly losing 10, 20, 30 pounds, and then reaccumulating those pounds. When they lose the weight, they'll also be losing lean tissue. When they gain the weight back, they probably will not be gaining back lean tissue because these are not people who are into protein and resistance training. And what we could see is and again, I'm not anti these drugs. I think like, you know, there's part of me that is like, why didn't you figure this out when I was a kid? And so I could have gotten on them like my daughter's on insulin for type 1 diabetes and just like, I would have had like a semi-normal life. Like there's a little bit of me that's like, but then, you know, I feel like I've learned a lot too, and I'm happy with where I am today. But is it not possible that people jumping on and off of them, their actual weight over a long period of time looks static, but their body fat percentage is incrementally creeping up.
Yes, it's not only possible, it's happening. And I
Right.
think it's inevitable for so many people. When you use a GLP-1 medication, if you look at the clinical trials, the weight that you lose, 25 to 40% of that will be lean mass. That's in these clinical trials. Some people may lose less, some may lose more. That's fairly significant. It's not that out of range from what you see with other weight loss interventions, but it's very significant. And it's the ease at which you can now utilize these medications, drop weight, and then cycle on and off. That is the concern because that muscle's probably not coming back. Now, where does that leave you? It leaves you with likely a lower basal metabolic rate. So it's harder to burn calories at rest. So then it's harder to lose weight the next time. And we hear that a lot from patients who have tried once and did well and tried again, didn't do as well, and tried a third time and had no results from a medication. So it's diminishing returns. So there is a chance that we will, a very legitimate chance that we will look back at this time and say, uh-oh, we kind of harmed a lot of patients.
Right.
And that's a little bit scary. If I look at the patients I started on GLP-1 medications in 2021, 2022, hundreds of patients, how many are still on them? Very few, really,
Right.
very few. So this idea that someone can really sustain these medications indefinitely isn't realistic for most people. Most people don't want to be on a medicine that long.
Yeah. And is it that, okay, I would love to know as a doctor when you're seeing people get off of them, is it that the side effects are uncomfortable? Is it just the idea of not wanting to be on a medication long term? Do you know what I mean? Because there's
Yeah,
probably a
all
stigma
the
to
above.
that. It's all of it.
There is, yeah. I would say in the first couple of years, it was supply and cost were the major drivers of medication discontinuation. What we're hearing more commonly now is side effects, even in low level, just this not feeling great every day. That can affect you over time. It's like, I've had enough of that. Or I think I'm in a good place. I'm just going to stop this and go on my own. Now, we know how that's going to play out in most cases. But yeah, all of those reasons will lead to discontinuation.
Yeah, man.
So
So
then what happens?
so then what
Then what
happens? Yeah.
happens? Okay.
What's the
Yeah.
solution?
And again, everyone's different. So some people are able to maintain weight for some period of time. But if you look at the clinical trials, 2/3 of the weight is regained within a year. Many people will regain much faster, and many will regain more than they initially lost because of that resurgent food noise. The noise becomes a cacophony. That's the problem for a lot of people. So what do we do? Well, in some cases, we will use an older generation medication, things like phentermine, that truthfully people have probably tried already and don't really want to get back on, but we can use that to help stem some of the weight recurrence. In our program, we're in collaboration with others as well. We are evaluating different pathways to control hunger, the ghrelin pathway. So we can talk about that. How can we curb the food noise outside of the GLP pathway for that patient who's abandoned it, or for the patient who doesn't want to go down that route or doesn't want to have surgery, which would also affect hunger. So we really have to look at every single pathway available.
So ghrelin is really the hormone that produces hunger. That is the hunger hormone, right?
It is known as the hunger hormone. It is the only orexigenic, which is hunger producing, appetite producing hormone in the body, or at least peripherally in the body. And it's a really powerful hormone. Everyone's familiar with it. They know that feeling. It is released by the stomach primarily. 90% of it originates from the top part of the stomach called the fundus. And it is released at times of energy deficit. So that could be short term. You haven't eaten overnight. You wake up, you're hungry. Or before your next meal, it rises and then decreases after you eat. So that is what triggers you to eat. And it's very, very powerful. It's actually really interesting. If you look at early studies of ghrelin, it's actually fairly recently identified. 1999, it was discovered. Some of the early studies are really compelling. In one, they took healthy volunteers, put an IV in, and randomized them to receive an infusion of ghrelin continuously or an infusion of saline, so placebo. And then they had them go into a buffet line and they said, eat as much as you want, eat until you're satisfied, have at it. And those who received ghrelin ate 30% more than those who did
Wow.
not. Just the power of that hormone. And that gets to the root of weight and the why the willpower theory is erroneous. Think about that. That hormone is telling you to eat. It is telling you that you are hungry and you can't really combat it. So it's a really powerful pathway. And if we can alter that pathway even slightly, we can just calm down a lot of that food noise and get better control over eating.
And are there ways to alter that? I mean, that's what I thought the GLP-1s were doing. Are they altering that pathway?
Not directly. There's the one hunger hormone, so one orexigenic hormone. There's a couple of neurotransmitters in the brain as well. And then there's a bunch of anorexigenic hormones, so those that reduce appetite. GLP is one of those. So
Okay.
GLP actually reduces hunger. We're familiar with that when you administer a GLP agonist. We're basically boosting that pathway. So that calms hunger. These antagonize each other. So ghrelin and GLP and others in that pathway, the leptins and amylin and all these other hormones also counteract ghrelin. So if you boost GLP, you're bringing down hunger. They kind of oppose each other. That's a very oversimplification, but there is no current direct pharmaceutical or pharmacologic treatment of ghrelin. Those studies didn't really pan out. Early investigation. What we're investigating now is procedural pathways to reduce hunger. Now, the proven way to reduce hunger is actually, or ghrelin is surgical. So if you cut a large portion of the stomach away with a surgical sleeve, or you bypass it with a gastric bypass, ghrelin will reduce by half or more. And that's why patients who have bariatric surgery, they don't lose weight just because they're absorbing less with a bypass. They have less capacity, yes, but they're also less hungry. Talk to anyone who's had a bariatric surgery. Though most people don't want surgery. So what we have now started evaluating is endoscopic techniques to reduce ghrelin. That's what I specialize in, is in the non-surgical procedures through the mouth with endoscopic tools, endoscopes, like we've talked about previously.
Yeah.
In this case, we're taking advantage of the location of ghrelin production. As I mentioned, it's within the stomach. Okay, that's good. We can access that easily with an endoscope. And it's actually within the lining, inner lining of the stomach. It's right there. And so the cells that produce ghrelin can actually be eradicated endoscopically, is what we've now demonstrated using heat, what we call ablation, thermal ablation. And so we can go in and essentially burn in a very controlled manner that inner lining. It then heals itself, but then the cells are not there.
Oh, wow.
So we started down this pathway a few years ago and have now shown in our early studies that we can reduce ghrelin by roughly 50% with this procedure that is like, an outpatient same day procedure. It takes about 30 minutes.
Like laser hair removal, but on your stomach.
I like that. Yeah, I'm taking that. Yeah, it is like that. Yes. We are lasering, in a sense, the inner lining of the stomach and reducing ghrelin. So this is the only non-surgical technique of reducing ghrelin that's been shown. Now we are at this point studying it in many different realms, including patients who are coming off of a GLP-1 medication in this, what we're calling the maintain trial, to see if we can help preserve that weight loss. So calming hunger to preserve that inevitable weight regain.
Oh my God, that's amazing. So, okay, I mean, like, I've done crash diets. I mean, listen, when I say the reason I didn't overeat was the reason I overate wasn't strictly hunger. That's true, but I also completely understand hunger. Like there was a diet that was popular maybe in the early 2000s, early 2010, somewhere around there.
HCG.
HCG, and you eat 500 calories a day or something like that, and you get this hormone. And to be completely honest, I don't know that I was very hungry while I did it, but I could power through that. When I stopped doing it, I was ravenous. When I
Right.
was off the diet, when I was done and I'd lost 30 pounds, and I had that experience where I'd do it for a month and then gain that weight back and go like, okay, I'm going to do this again. And then I'd only, instead of losing 30 pounds the next month, I'd lose 25. And it just would slowly tick down to the point where it's like, I'm now gaining back more weight than I'm losing almost immediately. But you guys can turn down that feeling of hunger.
We can, yes. And there are probably more effects, which I can get into as well. I just have to comment on HCG. This
Yeah.
is always like, if you want to identify a scam
I
practice,
mean, look, but there's so many scams. But yes,
so many.
and that was one of them. It was like, I was told like you're gonna take this and you won't lose any lean tissue. Suddenly, your body's gonna protect you, and because that's always been a concern of mine. Like I would do these crash diets, and I'd be like, I'm weak.
Yeah.
I'm not strong. I feel powerless and all of this. And then suddenly there was a legit doctor who was like, well, we have a new diet and this is going to protect you. And so, yeah, man, total scam.
Total scam. Yeah, HCG is clinically proven to do nothing for weight, actually. And so it is always paired with a very low calorie diet, which is, I'm sure, what you did. And it's like 500 calories a day. Of course, you're going to lose some weight for a period of time, but the
Yeah.
actual injection might as well be a placebo. But anyway, that's a separate issue. The good news with all of the GLPs available, that has mostly faded away, though it's still around there. It's out there. But let's talk about, so with this type of procedure, which by the way, still investigational, we are still studying it. We're still in the early phases of understanding every effect of this. But what we've clearly shown is ghrelin goes down. Yes, that's great. It also affects meal capacity. So patients eat less. Now, is that just because of ghrelin? Possibly. They're less hungry. We know ghrelin also affects stomach emptying. So at higher levels, as ghrelin increases, your stomach actually will empty faster. So as we decrease ghrelin, we will slow stomach emptying. So maybe there's greater meal retention. But also the thermal effect of that, ablating that area of the stomach causes it to tighten.
Mm.
And I think that may be even a more powerful effect. And this is, we're getting into the weeds here a little bit. But if you look at the top of the stomach, it's a key part of your body that controls when your brain says, let's stop eating. Because as that expands, there are these receptors, mechanoreceptors at the top of the stomach. As it expands with food, those trigger nerve signals to go to your brain and tell you, okay, we're satisfied. I'm going to stop eating now. By ablating that area, it tightens down, it shrinks down, and that set point, those mechanoreceptors register earlier. And so you eat and you say, I am finished with much less. So there's probably some benefits even beyond ghrelin. But what we hear consistently from patients who have had this is, I'm just so much less hungry and I have greater control over eating. And that's really important. Control to resist overeating is one of the endpoints we've looked at in our studies. And that's a powerful achievement when you have it.
Yeah. Okay. So when I was probably 12 years old, I gave myself a tattoo with India ink wrapped around a needle. My mom saw this, took me to the doctor, said, get this off of him. And he was like, well, we can do two things. We can give him a giant scar and cut it and sew the skin back together. And we were just in like a family practitioner's office. And he's like, I'm not set up for this. Or we can laser it off. And she was like, laser it off. So in one go, he lasered it off, which turned that whole section of my skin into like very severe 3rd-degree burns. Then I got a really dumb tattoo as a cover up of the burn when I was probably 17 or 18. And then when I had kids, I was like, I got to get rid of this tattoo. So I went and had it properly removed. So I've never done laser hair removal, but I have done tattoo removal. And for tattoo removal, I think I had to do like 13 trips to get this tattoo removed. And I can still see a very, very faded outline of it. But with ablating, I think is what you called them, the stomach lining, is that a one-time thing, or do you have to go and do it a bunch of times?
It is a one and done. So it is
Wow.
very different than what you're describing with tattoo removal. This has been studied in beginning with animal models onward. We and others have studied the proper settings we use with the device and the end result that we achieve. And we know the exact technique now to eradicate that entire mucosal lining, that inner lining. And then it heals and replaces itself. So it does go through a healing phase. And we have to, safety is always the priority. So the stomach has to heal. We have to protect it during that time just by lowering stomach acidity for a bit. But then it looks brand new. It's fully healed. And if you look under the microscope, there are fewer of those ghrelin producing cells. But it is a one-time procedure. As far as we understand right now, the thinking is those cells won't return because they've actually been replaced with fibrotic tissue, kind of like scar tissue, much like your skin after a lasering.
Yeah.
Will the body produce ghrelin elsewhere? I think that that's certainly possible. And so there are some other areas like the small intestine that produce ghrelin. So we would imagine over time some return of hunger. We're still evaluating that. But that's why I think some of those other benefits are maybe even more important long term.
And lowered acidity, what does that mean?
Oh, like taking a Nexium for a couple of months, Prilosec, just to protect that area that we've ablated.
Right. And is there, I imagine having something put down your throat is not the most comfortable thing. And so there's that, but are there nerve endings in the stomach? Like, is there like a painful recovery from this?
Yeah, you're exactly right. There aren't any nerve endings, and so it's actually really mild. It's something that we had to really define, and we didn't know when we started this. Now, the technology that we're using is used in the digestive tract to treat smaller areas, lesions, things like precancerous changes in the esophagus and stomach and elsewhere. But we're treating a much larger area with this technique. What we've learned is the recovery is minimal. Symptoms are very mild. Some patients describe feeling almost nothing because there are no nerve receptors there. So other than some gas pressure and mild cramping, we have found the recovery to be very fast.
Oh, wow. Okay, amazing. And so you go in, you have this done. Is there a special diet? Like what all goes into it? I mean, I've got 1,000 questions. I would love to snap my fingers, not have to do anything you're saying, but to get rid of half my ghrelin would be amazing, just because I feel like it would make my life a lot easier. I would have to make a little bit less intentional choices. But what is the process? Are you putting people to sleep for this?
Yeah, it's under anesthesia. And so the process at this point is about a 30-minute procedure under anesthesia. It's not much different than coming in for a diagnostic endoscopy if you had, stomach symptoms, but it is under complete anesthesia. And we perform that procedure. Patients wake up, they're able to go home, about an hour afterwards. So it's a same day procedure. And then they follow a fairly typical post-procedure bariatric diet. We want to slowly introduce food over time. So they're on liquids for a period of time, and then advancing onward to soft foods and regular foods, very similar to our other weight loss procedures.
But it sounds like it's a lot less than if you cut half of somebody's stomach out, right?
No cutting. A lot less. And that gets to the risk profile as well, where you just don't see those risks that you would associate with a traditional surgery. So that's why this may be a more acceptable option, or procedures like this would be a more acceptable option for patients who really aren't ready to make the leap to something truly surgical. We're trying to bridge that gap and offer as many options as we possibly can. Now, we are offering this to patients who, by itself as a procedure, though I will mention the weight loss is less than a surgery, definitely. It is about 10 to 15% of body weight, which is significant. It's equivalent to Wegovy. We are also combining it with some of our other endoscopic procedures, like the endoscopic sleeve that you and I talked about last year, which is greatly enhancing the weight loss, even of that procedure, really equal to surgical. So,
I know we talked about it, but will you refresh me? Because I do not remember exactly what that entails.
So the endoscopic sleeve involves going down, through the mouth into the stomach, using a very small advanced suturing sewing device on an endoscope to stitch the stomach from within to make it about 70 to 80% smaller. So we're mimicking a surgical sleeve, which is the most common bariatric surgery, but performing it without any cutting, any incisions, which is, again, lower risk, shorter recovery, still significant weight loss. But if there's one disadvantage of that procedure, it's that we aren't cutting away that top of the stomach that I mentioned is hormonally so powerful for hunger. And so what we're now probably most excited about is combining this ablation with that procedure to fully replicate a surgical sleeve.
Oh, wow. Okay. And so when you stitch, how long is that a permanent stitch that would have to be removed at some point, or does it dissolve over time? What is the lifespan of the lessening of capacity?
Yeah, it's a long-term procedure. These are non-dissolvable sutures that we use, and we're relying on those sutures to hold the stomach into its smaller shape so it heals into that shape. And that's really what's happening, which is why there's a many-year impact. We now have studies 10 years out from the procedure.
Oh, wow.
Now, as you are well aware, no procedure is permanent in the sense that it will help you keep weight off forever. So that's always going to be an ongoing battle, but the tool itself is there supporting you.
Yeah, I mean, look, you listed a bunch of them. When I'm thinking about any of this stuff, I think that these are all incredible tools, and the GLP ones, great tool. Seems like people are having a lot of success, but none of it is a total like none of it is just, you know what I mean? Like forever in dieting, I looked for the one trick pony, the like just give me one thing and that will be my solution. Don't eat carbs, great, I won't eat carbs. Never got me to where I wanted to be. It just didn't. I could lose some weight and then I'd be kind of spinning my wheels going like, why isn't this working anymore? I'm certainly not at a healthy weight and I'm not eating carbs. And like, I would then have no motivation to continue, give up, gain the weight back. But I think what you're saying too is like, look, we can do these procedures which will produce profound weight loss, but it's not going to be a forever permanent solution. Like it does require personal intervention also.
Yeah, absolutely. So any intervention has to be paired with diet and lifestyle modification, of course. What we like to tell patients is that this levels the playing field
Right.
in many ways. And so that the effort that you put in actually works, you actually
Yeah.
can see results. And that is a big difference. And these options may not be for everybody, but we need as many options as we can possibly have when we understand that 3/4 of the US population has overweight or obesity. There can be no excess of options for patients, and the more the better. And for some patients, it'll be a medicine. For some, it will be diet and exercise. While overall, they're not terribly effective, for the individual, they can be. And
Yeah.
you've certainly shown that. And then for some, it'll be surgery, some it'll be endoscopic procedures. You know, the more options, the better, but understanding they are just tools.
Yeah, I mean, I talk to all sorts of different people, you know, and I've talked to people who have had great success with GLP-1s and they're very happy with them. But again, I haven't talked to them long term. It's not like I've talked to somebody who went like, I started on this medication, I lost all the weight I needed to lose, I'm continuing on the medication, and everything's going great. But I think it's all still relatively new. But I've talked to a lot of people who have tried to take them and are just too the side effects are too much for them. So it's not like those are going to be universally beneficial either.
That's right. It's been really fascinating to see the evolution of this, just from my own perspective. You know, us in the field of weight loss, 1, 2, 3 years ago, patients coming to us would explore all options, including medications. We'd talk through the pros and cons. That doesn't happen anymore because pretty much every single patient that I see has tried a medication. Everybody. And what we're seeing in the field, in the bariatric field especially, is this evolution of what the patient looks like who comes to us. Now, bariatric surgery numbers went way down in the past year or two. It's well documented. Last year, 25% decrease in surgeries. That's not surprising because someone who might be inclined to have surgery will first try a medicine. It makes a lot of sense. But what we're now seeing is those patients coming back to explore the surgical or procedural options. And so many have described having this like taste of real weight loss. Like, that medicine really worked. I actually lost weight. I was less hungry, but I couldn't continue it or didn't want to for whatever reason. I'm ready to take that next step so that I can have an intervention that does the same thing, but is much more durable. So that's really what we're seeing now.
Yeah. Well, the other thing about the medications, which we haven't talked about, is the price. I think they're like $1,000 a month, and then forever, just forever. You know what I mean? Like it's not like $1,000 a month for 2 years, and you go like, well, this is going to cost me $24,000. No, it's for the remainder of your life if you're really thinking about it, which to me really could become a staggering amount of money to pay. and
Staggering.
out of the realm of possibility for a lot of people.
That's correct. And insurance coverage is definitely not universal. It's still a minority of commercial employers or payers will cover these medications. And the numbers are staggering. And anytime I start a patient on these medications, we have that conversation. Like, let's really map this out and understand what it looks like. The problem is we have that conversation, but most people sort of ignore that second part, the forever part, and still think, well, I can beat the system. And I
Right.
understand
I'll
the
do it for
mentality.
2 years or
Yeah,
6 months or whatever it is. Is it worth $6,000? Yes, absolutely. Right. What about the procedures you're doing? Are they covered by insurance?
not yet. So the ablation that I was discussing, very, very new, that would be years away. The endoscopic sleeve is about to have coverage. So I think that was the big development this past year. It received what we call a CPT code, a procedural code. It's a really important step in the evolution toward insurance coverage. And so that becomes live 2026. And we believe at that point, we will start to see insurance coverage finally for this really effective, important procedure that is still self-pay at this
Right.
stage. So that is coming.
Okay, and then I had another question to go back. Sorry. There's just so much that I think about, and my head gets kind of, I'm swimming in every potential. Like, if I was going to go and do this, what would be all my questions? And I want to try to posit that for people who are listening. When I guess the last time, and pretty much the only time my wife ever said to me, like, hey, and we've been together forever. Her and I started our relationship when I was at my heaviest. So there's never been a feeling from her to me of like, I want you at a different weight, or that, it's been like fairy tale for me growing up a fat kid to have a girl who actually like really just didn't care about my weight. Was like, what kind of home run have I hit here? But in 2016, I had put on a bunch of weight. I was back up to like 400 pounds, and I'd ruptured my bicep doing a fight scene in a TV show. And I was on the phone with this specialist. I was shooting in San Francisco, on the phone with a specialist in Los Angeles. Like, okay, we got to set this up. I got to get this done right away so that the tendon doesn't die or atrophy or whatever happens. They want to do that stuff right away. And when I finally got to his office, he was like, oh, this was meant to be done in my office or in this like medical center. You don't qualify. You have to go to the hospital. You're too big. And that was when my wife was like, hey, I didn't like that, made me uncomfortable because of your health risk, because the risk to your health in doing a medical procedure, you have to go into a hospital, have many more people watching you to keep you alive, basically, for your safety. And her point was, just get under that number, whatever that number is, get under it so that you qualify for the kind of outpatient or in the clinic kind of procedures. And so I'm asking because I imagine you see many people over that number. But when I think about half hour and endoscopic thing, I'm thinking that that's in a clinic. But if somebody doesn't qualify, do they have to go into a hospital? Like, do you do both those things?
Yeah, that's a great point. And there are definite cutoffs in the field for an ambulatory surgery facility or procedure center versus a hospital. The cutoff is typically a BMI of 50, at least in our world and for our procedures. So we're able to treat the vast majority of patients who reach out to us. Though those who might be above that level, we do have in our center, a hospital facility that we will treat patients in. Still outpatient, still same day. From a procedural standpoint, anesthesia standpoint, nothing is different. It's just a setting which relates to anesthesia risk.
Yeah.
It's never my favorite thing to discuss with a patient because it's so arbitrary. Like, I'm really sorry, we can't treat you here. We have to treat you there. Like, it just doesn't feel right. But
I imagine it comes up. Yeah.
Yeah, it does come up. That's right. The worst thing is to say, like, I wouldn't necessarily volunteer this to a patient, but to say, well, if you can lose some weight, we can treat you in the office. Like I don't like that at all. But patients, of course, will approach that themselves and say, I can do this maybe, get my weight down a bit and have it done in the office, which is, more efficient, lower cost, all of these factors. So it's definitely something that needs to be considered for certain patients.
Yeah, I mean, well, there and then there's the factor of like a lot, not a lot. I haven't talked to that many, but I've talked to a handful of people who have had it's a lot of technical words here. So I'm sorry, I'm a moron talking to a doctor. So try to get what I'm saying. The full cutting out of the stomach removal,
Hmm.
and most of them have to lose weight before the procedure anyway. Most of them are being told prior, like, you have to prove to us that you can do this, which to
Yeah, isn't that
me,
nice?
yeah,
Yeah.
I mean, it seems like motherfucker, if I could do that, like, why am I, I'm coming to you because I'm having so much trouble with that. But I also think, like, if I came to you and you were like, I imagine everybody that's been to see you has tried dieting to some degree. And I would imagine most of them have seen some weight loss. So if it was a matter of losing 20 or 30 pounds and saving a bunch of money and not having to be in that setting, because that more hospital setting, it feels creepier. You know what I mean? Sorry, I know this is where you work, but for me as a patient, the difference between being in a doctor's office and going in another room that's sterile is a lot different than checking into a hospital facility. And it's just it seems extreme. And then you're like, well, I'm here because it's safer and I pose some risk. So I would think losing that 20, 30 pounds, whatever it is, but then you could probably get into the numbers where it's like, I'm never going to do,
Yeah,
if it's hundreds
that's
of
right.
pounds. Yeah.
Yeah, it's the only scenario where we will embrace that idea of we're actually going to go on a strict diet ahead of a weight loss procedure. It is that scenario. That is it. Now, with traditional bariatric surgery, you're correct. There's a lead in to having that surgery, and it varies based on program, based on your insurance. A lot of times, it's driven by silly insurance hoops. Like, you have to demonstrate you can lose weight to have surgery. Idiotic.
It seems
Okay,
so crazy. The first time
idiotic.
I heard that, dude, I was like, wait, are you kidding? It's a joke, right? No, but they were very serious.
Yeah, and it's rarely driven by the physicians. The other thing that patients who have traditional surgery have to do is usually a 2-week liquid fast, which is considered a liver reduction fast, because surgically you have to get to the stomach through the abdomen. The liver can get in the way. And so if you go on a liquid diet for 2 weeks, the liver actually shrinks down in size. So that is a medical reason for that, but we don't need to do any of that before an endoscopic procedure because we're working from within. So patients often say, okay, do I have to do a 2-week fast? Because they've heard of this from others. And we say, absolutely not. In fact, I want you coming in strong. I don't need you coming in depleted.
Right.
There's just no need
That
for
was,
that.
yeah, dude, that was another thought I had hearing about this fast. Like, your body is at a weakened state. Like, you're just not as vital, I think, after fasting like that.
That's exactly right. And so we do a 1-day liquid diet before the procedure just to make sure the stomach is empty. And I will tell you that without a doubt, the hardest day in the entire process is that day before the procedure.
Right.
1 day of liquids. And it is a struggle because you have not had the procedure yet. And so once you have a procedure like these, you're just much less hungry. And so you can really deal with that more easily moving forward.
Okay, and is this the ablation of the ghrelin cells? Is that something you came up with?
No, I can't take credit for that. I was the first physician to perform the procedure in a human, but there's many collaborators that I have worked with and continue to work with who have really been instrumental in developing these techniques. And others internationally that we still collaborate with. But I was the first to perform this procedure, to take the leap and to really focus on the fundus. The early design of studies looking at this was really, they were looking at mimicking that surgical sleeve. So ablating kind of the middle of the stomach. Whereas, my interest was the fundus primarily, knowing that it was so hormonally active. So we've definitely led the charge towards the fundus. But we do have other ongoing studies in collaboration with those like Mayo Clinic, who have been real pioneers in this as well.
Yeah. It seems like it seems like the idea of what you're after is one of the last pieces to the puzzle of just like that kind of reduction in hunger because sorry, I just got a notification that my internet is unstable. You see me? We good?
You paused for a second.
Okay.
Yeah.
Okay, but we're good now?
We're okay now. Yeah.
Okay.
Okay.
My you know, despite everything, there is still in any diet you do, any intervention you take, you have something cut out, you have something made smaller, you take this drug, you go on the painful fast, or you do the yo-yo quack Hollywood diet. The end is there's still other stuff to deal with, and hunger. You have to confront hunger, and the idea of a reduction in hunger does seem like a puzzle piece that, I don't know. It's just, I haven't heard, I'm trying to think back through my life of any intervention that like directly dealt with hunger in that way. And I can't think of one. I mean, when I was a little kid, I was put on Ma Wang, which I was such a little kid. I didn't sleep.
Right.
It was
That's
brutal.
good for a kid.
Right. Yeah. It was a nightmare, honestly. And then later as a teenager, Fen came out and it was like,
Sure.
let's try this. And both of them were the net result was like, I was bouncing off the walls, couldn't sleep. My life kind of had a meltdown, and I was very quickly taken off. So I didn't see if like I lost a bunch of weight because they were just did not react well with me.
Really tough to tolerate. Yeah. Though they do curb appetite to some degree. So
Right.
the phentermines, the fen-phens, yes, they do. Newer medications, even before the GLPs, also do curb appetite to some degree, just not enough for most people, which is why the GLPs were so revolutionary, because they really quiet the hunger for many people in a much more powerful and sustained way. And now we, of course, have these other things we're exploring, but it's such an important component when you're looking at a tool to treat weight. We can't just reduce capacity. That's probably not sufficient. We also have to affect things centrally, calm the hunger via the brain, which is so powerful. We really have to hit this from all angles that we possibly can.
Yeah. Do you, as a doctor, as a medical person, do you ever get frustrated because seeing, I don't know what the latest diet is. Maybe it's still carnivore or something like that, where it's just, or, any of the crazy ones. I remember Fit for Life was an extremely low calorie diet. And then there's something called My First Personal Diet, which is not personal to anyone. You pretty much just eat like 1,100 calories a day, no matter what size you are. Or the Ideal Protein Diet, which is a crash diet. There's all these diets. And I found even when I was doing diets like this, the carrot that was initial weight loss kept me coming back time and again. I lost 30 pounds. I'll just do that again. And even if I only lose 28 pounds, that's 28 pounds. Or we could take keto. I've done keto maybe 20 times. And every time I lose over 10 pounds the first week because I'm flushing my system of glycogen. I know that now, but that result, even if the next week I only lost 1 pound or no pounds, that first week, that incentive kept me coming back over and over. There was no, and I don't really like the word holistic because my mom was a hippie, and holistic meant, when I got sick, I got an alcohol dropper under my tongue of something that did nothing, right? That was holistic medicine to me. But I do think for weight loss, the idea of holistic, just in that it's going to be more than one thing, right? It's like your entire life has to be taken into consideration. Do you get frustrated seeing people on this cycle where it's like, I lost 15 pounds on keto, I'm going back to that, though it came back every time you did it?
I don't get frustrated because I can definitely understand it. And really, until recently, what options did you have? Did anyone have? There just weren't many. There was diet or surgery and nothing in between. So I can understand that. But I can also understand that there's a massive marketing machine behind so many of these diets, and there's so much misinformation. And this diet's better than that diet. Look, all diets are the same. If one works for you, great. But there is not a diet that is better than another. Millions and millions of dollars have been spent researching this. There's no winner.
Yeah.
Okay. If you find one that works, great. Do you know many people who have stayed on a keto diet long term? No, right?
No.
It's
Yeah.
not sustainable. Um, my goal with my patients is to find a sustainable path, whatever that may be, whatever that may look like, but it's not likely going to involve a gimmick. It's not likely to involve something overly restrictive. And someone who has a procedure for weight, the end goal is to eat normally, just smaller portions, to feel satisfied with less, to not feel like you're struggling to eat less, but it's not extreme. That is a path to sustainability. Like that can continue year after year after year. If you say, I'm not eating this or I'm only eating meat, like that's crazy. You'll never be able to do it.
Yeah. Yeah. Well, I think it's radical what you're doing. And I love that you are pushing it and finding new interventions. And this new intervention sounds, I mean, it makes me feel hopeful. It sounds like something that would be very helpful to people. Um, and I'm glad you're being inventive. You know, I think it's so cool.
There's so much, so many directions we can go. There's still so much hope for patients who need help. It doesn't stop with surgery. It doesn't stop with the GLP medications. We are really just getting started as a field. There's so much more interest in this field than ever before. And that's really exciting. So what it looks like today will look very different next year and beyond. And we want to get to a place where we have the safest procedures, the most effective procedures, and the most accessible options for patients, so that they can actually obtain them. So these are all the goals.
Yeah. I mean, just to put myself, I was for sure a candidate for having part of my stomach removed. And I was just scared. You know, I think that is what stopped me from ever going down that path, was just fear of like being cut open and having a big chunk of myself removed. Like it just freaked me out. I was like convinced if I did something like that, I would die. So it was like, why do that? And the fact that you're doing these kind of interventions that are so much less risky is amazing.
Yeah, fear is the number one barrier to entry into the surgical realm for patients. We know that it's been long established, even though it's really safe. The actual surgeries are really safe. The often cited metric is that it's as safe as a gallbladder surgery. Though people die from gallbladder surgery, you
Yeah,
don't
I had
actually
a
think
terrible
about that.
Yeah,
Yeah,
I didn't
terrible.
die, but I
It can
had a
be.
terrible gallbladder surgery.
So, yeah, overall, really safe, but things can happen. So we know that, which is why patients at this point who have tried a medication and maybe come off of it and are thinking of that next step aren't thinking about surgery. They're more interested in these less invasive techniques. So we're really seeing a rise in interest in the world in which I live, because, again, safety being the priority. But we know that it's scary to think about even just going under anesthesia is scary to patients. So the shorter we can make a procedure, the safer, the shorter downtime. That's really the goal.
Yeah. Yeah. And in and out in an hour, or, you know, the procedure's a half an hour, you're out in an hour or so. Like that sounds way more confrontable than, you know, multi weeks of fasting to get your liver down because they got to move it to get into an area to cut you. You got scars. Like it just seems more palatable to me.
Yeah, and it's analogous to the days of where maybe a coronary bypass was the only open heart surgery was the only option if you had a
Right.
heart attack, and then stents came around, right? And suddenly that's a same day procedure and changed that field. It didn't eliminate the need for a bypass in certain scenarios, but it made the whole process much safer and quicker. So patients who are having an endoscopic weight loss procedure can have it on a Friday and be back to work Monday. That's a big deal.
Right.
That is very different than 6 weeks of recovery time from a surgery.
Right. 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 Amazing. Well, but yeah, it's quite a bit different than having it in the afternoon and going back to work the next day too.
Right. Yeah.
Yeah.
So this is all evolving rapidly. In this field, we will see robotics entering this space very soon, which will have other potential advantages. And the end goal, again, being most effective procedures with the safest risk profile by far.
Yeah. It's amazing. Dr. McGowan, thank you so much. This has been an awesome conversation. I really
Thanks so
appreciate it.
much. Great being here again.